In this study, we investigate the use of ventricular assist devices, or VADs, in single ventricle patients who have had the stage 1 Norwood surgery. In this type of circulation, the pulmonary and systemic blood flow are in parallel. The increased volume loading on the heart corresponds to an increased risk of heart failure. VAD implementation in these patients are not well understood, and there is the need to improve clinical outcomes of these patients. A primary consideration for ventricular assist in these patients is whether to use a continuous flow or a pulsatile flow device. There is some amount of anecdotal clinical experience that continuous devices seem to produce better clinical outcomes, but there is little published documentations. In this study, we used computational modeling to reveal that in these patients, the flow output of pulsatile devices is limited by filling when the device attempts to draw blood too fast from the ventricle and induces significant suction resistance. This is the computational circuit model we used to simulate patient physiology and VAD implementation. We constructed a total of 6 patient-specific models, each tuned to a set of clinical measurement data from a patient. The pulsatile device is modeled after the Berlin heart, which is driven pneumatically. This produces a pressure waveform inside the device as shown in the left figure. The continuous device is modeled after the hardware pump, with pressure versus flow characteristics as shown in the figure on the right. An important aspect to consider in the model is the flow resistance resulting from the inflow cannula suction, which can collapse the ventricle. This suction resistance is inversely related to the distance between the cannula head and the opposing ventricular wall. This distance we call the squeeze factor is represented here by the delta sign. Based on the heart geometry data published by Dawson, we identified an allometric scaling relationship between the suction resistance and body surface area. We combined experimental data from several previous studies, normalized them by body surface area, and performed a best fit to estimate suction resistance as a function of the pressure at the head of the inflow cannula. Suction begins to occur when the ventricular pressure is less than 0. Total occlusion occurs when the opposing wall of the ventricle is sucked onto the cannula head and makes direct physical contact. When this happens, some amount of ventricular pressure is required to pop off the cannula from the tissue. This pop-off pressure is related to the size of the ventricle, the pressure inside the cannula, and the diameter of the cannula. We estimated this relationship by approximating the ventricle as having a circular disc shape when it is collapsed, and using data published by Troy to relate ventricular size and body surface area. Lastly, we used data published by Nikolic to derive ventricular pressure as a function of ventricular volume when the pressure is negative. Here are simulation results averaged across the patient cohort. For a pulsatile VAD, the expected output is the size of the device times the pump rate, but we're seeing here that at higher pump rates, the actual output is lower than what would be expected. Notice that the continuous VAD is able to produce a higher maximum output than the pulsatile one. The output limitation of the pulsatile VAD is due to the decrease in stroke volume at higher pump rates. We saw in the simulations that this decrease is due to incomplete filling, and the phenomenon is more pronounced with larger sized devices. We also attempted to optimize pulsatile device settings from the current clinical guidelines. No statistically significant improvement was obtained, implying that the current clinical guidelines is already optimal. The pulmonary and systemic circulations being in parallel requires higher cardiac outputs than normal. Now, if you want to increase the flow output of the pulsatile device, you would increase device size or pump rate. Both tends to cause incomplete filling. Continuous device tends to be able to produce higher cardiac output, and this performance difference can be explained with the concept of duty cycle. When a VAD is sucking blood from the heart, there is the potential to collapse the ventricle and drastically increase suction resistance. The continuous device is pushing and sucking blood both at 100% duty cycle, where the pulsatile device does each for only a fraction of the cycle. This means that the pulsatile device would need to draw blood harder for any given flow output, resulting in limited performance when implemented on a small ventricle.